Can you hear me? Let me check my.
How about now?
Ah, there we go.
That was my bad.
That's okay. No worries. No worries. How you doing?
Now, I'm nervous. I'm never nervous about this.
Don't be nervous. Everything will be just fine. I promise.
I hope so. I usually do this in person, so I'm much better in person than I am. You know, it's just different.
Well, it's in person. It's just with a screen in person.
Yeah. I'm actually teaching a coding class, and we're going to start doing the Teams meeting, so it'll be like this with everybody. We're going to try that tomorrow.
Mm-hmm.
But with the Zooms thing, I just wasn't sure, you know, how is it the same? How do I share my screen? Which is really important.
Yes. So if you kind of take your mouse and kind of go down to the bottom, you'll see some menu items, security, participants chat, then right in the middle it says share screen. Yep, okay. That's the one you want to hit. And then
I want to share that.
Mm-hmm.
Okay, now when I'll see everybody on the right-hand side.
Yep, and now I see the basics of documentation and coding.
Right.
So that, and this is, you know, just your slide as if you're going to edit your slides.
Right, right.
Yep, that's what I see. You're good to go.
Awesome. Yay, well, I'll give you your time back. Do you have any idea about how many people are going to show?
Honestly, I don't. Hope it's mandatory, I believe. So hopefully the majority of folks will be tuning in. So fingers crossed on that one.
Yeah, Dr. Stevenson's in person. She's pretty demanding that they join, and it's a good thing. This is a good thing. All years, I don't have the coding cards though, and so I've got to teach the OBGYN residents in the morning. So I actually have to go to 2 Med Park, and I can bring you some coding cards if you want me to.
Sure.
Where are you located, Ashley?
I'm in 9 Medical Park,
okay.
Suite 200.
Okay, Suite 200. Okay, so I could just slide over there and hand you some so they'll have them. If they'll just let you know if they want them.
Okay.
Or I could just bring them, and then when they come see you, if they decide they want one, you'll have them there.
Okay, and you can certainly, you know, let them, you know, mention that in the presentation, and I can put them in their boxes, and they can probably chat with you and all that good stuff. So
okay,
to take them.
Hopefully there'll be some new people here, because I know the 3rd and 4th years are like, yeah, we've heard you a couple of times, Tina.
Well, Colin, who just logged on, he's one of my 1st-year residents. So we got
good.
We got one newbie.
Good. We're actually, hi, Colin.
There he is.
I'm actually doing this again on Wednesday in person with Drs. Tracy and Frank Voss. I don't know if you're familiar with them. for the internal medicine residents, and I think it's going to be broadcast to all of the residents.
Yeah.
So if somebody didn't get to join today that really wanted the information, then maybe we could get that information, or maybe they can tune in on Wednesday. Not sure how that works.
Yeah, we'll figure that out.
So Ashley, did you take Melissa's place, or do you work just for the residents? Or
I work just for the residents. I have been here with the department since April of '97.
Oh wow,
So
23 years.
I've been here a minute or two. So
yeah, the only reason I know that is because my daughter was born in '97.
There you go. There you go.
Good year. So you and I have probably met. I just don't remember.
I'm sure we have.
At some point.
Yeah. I'm old as, Methuselah, so what can I say?
Yeah, me too.
I've been around here just as long.
I hear you. It's a great place to be. I
can't imagine being, well, I wouldn't be anywhere else, I'll be honest. So they're stuck with me. I'm like an old shoe. They can't get rid of me.
It's a good thing. This residency program means a lot to a lot of people. So I'm very glad that we can offer it to them.
Absolutely. Thank you so much. Really appreciate it.
Sure. I do. I'm glad I'm talking to you. I'm feeling less apprehensive.
Good. The good thing is pediatrics, we're so friendly, we're good to go. We're easy. No formality in this group. I can promise you that.
Well, that's good. That's really good. Well, you can't be with children, right?
That's, you got to have a light heart and a smile on your face. And that's just how we roll anyway.
Right. Well, and if you don't, then a child is going to warm your heart or scare you to death or something. You can't predict what's going to happen in peds.
That's so true. That is so true.
I onboard all of the new providers that come to the medical group. So they come to my class before they actually go out and start billing and all that.
Sure.
Regardless of if they're new or not. And we've gotten a lot of new peds physicians lately. I'm very glad to see that.
We're just continuing to grow, which is, a great thing.
It really is. And I mean, like we have Dr. Arith got help. Hallelujah, praise the Lord. That man has been by himself for years.
I know. Finally, we decided not to make him, ride solo anymore. So.
Oh, and just so you know, we have a female urologist for the adults now. Woohoo.
Nice.
Yes, so we have 5 males and 1 female, and she is so glad to be here.
Awesome.
I would imagine she will be busy probably next week, like swamped.
I can't imagine. I'm sure she'll be book solid.
Yeah. The medical group is really, well, I don't even know if we're going to be what we're going to be called, but for the purposes of today, we're the medical group, right?
That's right. Whoever we are. We're just great. We'll just call us the great group. How about that?
That sounds wonderful. I usually have 3 to 4 people join that new class and it's every other Tuesday. So it's whenever anybody onboards, it's the day after. I had 12 new providers in that class. 12.
Wow. What's your average?
Nowhere else to sit.
Wow.
I was very excited about that. So that means we're growing. We're increasing our numbers in the specialties we already have, like pulmonary /sleep /critical care and urology. We're replacing a few physicians who have left, but as a whole, we're adding new providers with new knowledge or a subspecialty and a specialty and that sort of thing. So it's very exciting to see that.
Yeah, I think we have a rheumatologist starting here pretty soon. Has Jody Dingle come through your?
Nope, not yet.
I can't remember exactly when her start date is, but I think she should be here shortly if I'm not. Well, hello, Dr. Stallworth. How are you? I saw you in my.
Where is she?
She went to lunch. She'll be back. You meet her?
Well, she's been gone for a week. What is her issue?
We still let her eat.
No, we don't. No, she's been gone. She's right here.
What can I do for you, love?
Just remind her, when she puts out the grand ring. Grand rounds, okay,
Students still come.
okay,
You know, they're the only ones that come
physically, yeah.
physically
Mhm.
there. It's at 7:45, remember, because this is the connect.
Oh, is this the joint one?
This is the joint.
Okay, yeah,
And just that the students, when she sends out, say, students will be in the audience, or however she wants to say. Okay?
okie dokie.
Voice contract vacation goes on lunch. Someplace you run around.
So, and I know you know Dr. Stallworth well, because
Absolutely.
everyone does, you know.
So the rheumatologist, is that a peds rheumatologist or is it just a
She is.
rheumatologist? The name sounds a little bit familiar, but I don't remember meeting, and I know because I have rheumatoid arthritis.
Oh,
So
yeah.
in fact, Dr. Day, who is one of our sort of newer rheumatologists at 2 Med Park, is going to inject the joints of my fingers Wednesday. I have 2 fingers that are really, really swollen. Yeah,
Ugh,
it
that sounds
hurts.
horrible. Bless your
Those
heart.
shots
I'm
hurt.
so sorry.
It's okay because
Sounds
the,
awful.
the shots do really hurt, but the medicine works better than anything. So I'll be sore for a day or two, and then I'll have 8 or 9 months of feeling much better. So I mean, it's a good trade-off. It could be a lot worse.
Last longer than that, though.
Yeah, that
Give you
I've
at
had
least a
plenty.
good year.
Right. Yes, I mean, he is fabulous too. He did his residency here and his fellowship in Alabama and came
Mhm.
back. So I love it when the physicians have to leave for whatever reason and then they come back because you're like, yay, you liked us enough to want to come back.
Yeah, that says something, that's for sure.
Absolutely. So I only see like 3.
Well, the folks in the PICU, that's more than one individual.
Okay,
So Kaylin is another first year.
good.
And people, they'll start trickling in. You know, it doesn't technically begin until 12:15. And, you know, Dr. Stevenson hasn't even logged on yet.
She said she wasn't going to. Someone else
Oh,
was
she's
going to
not
be.
going. Okay.
Somebody else is going to introduce me, I guess.
Dr. Carney, probably.
Probably. And I think I met him when he came. He's kind of helping take over some of the residency stuff. Is that right?
He's part of the residency program. He's the program director. Mhm.
Okay. So I onboarded him.
Yep.
When he first came. So, okay. I know who he is.
Yep. He's a good one. We'll keep him.
Yeah, we'll keep him. I didn't know because you had set the appointment for noon and she had originally said 12:15 and I was supposed to be giving a test,
Yeah.
proctoring a test today and that got canceled. So,
Well, I do that so folks can get on early if they need to,
right.
things like that, just to make sure that their equipment is running well and we can hear and see and all that good stuff. So I started a little bit earlier than
Okay, well, good.
technically it begins.
Well, I appreciate that very much. I feel much better about knowing I can set up and all that.
You are going to do fabulously. I know you will.
I don't know about all that, but
Sure. I just hope fingers are okay.
yeah, they'll be. It's my middle fingers, both of them. Isn't that funny?
Hey, what I do to you?
Both of them, yeah. And then he'll inject
it's from
part of my
overuse.
hand too. It gets really swollen,
Ow.
so he'll put some cortisone in there. Those joint spaces that they have to put the shot in, they have to do a little ultrasound first to make sure they're getting it in the right space. That's fine. The ultrasound's fine. It's the shot. I'm like,
Yeah.
holy cow, that hurts.
Oh, I bet. I mean, yeah, because you have all that feeling in your hands, and
Yeah.
bless your heart.
And you're putting fluid in a very, very small space, so it feels
Yeah.
like the knuckle is going to pop open. So there just a lot of, but you know, I mean, like I said, so I'll get that done Wednesday. By Friday morning, I will feel so good. It'll be worth it.
Well, good. Well, I'm glad it's at least worth it and gives you some good relief.
Absolutely.
It's temporary. It's better than nothing at all, right?
Right. Oh, I had both knees replaced last year, one in June and one in December.
Gracious, child.
Well, the rheumatoid arthritis makes osteoarthritis worse. So I had both. So my knees, I'm 52. My knees look like I was 92.
Gracious
the-
child.
But I have great knees now. Now I can exercise. I'm back to riding my stationary bike in a virtual spin class for 15 to 18 miles 5 times a week.
Look at you. That's
That's
awesome.
pretty awesome.
That is
That's pretty
awesome.
So if you know someone who is like, I need to get my knee replaced one day, but I'm just not ready, tell them to do it. I can tell you anything you want to know about it.
Now, is this going to last like forever? Like, are you?
It depends on how long it depends on how long I live.
Well, we're going to let you live forever. So if that were the case.
I don't know. I think they're thinking 25 years at least.
Okay. Well, that's good.
So
That's good.
they're ceramic and titanium,
Mm-hmm.
so they don't wear out like the plastic joints used to.
Mm-hmm.
So,
Yeah.
and Frank Voss did them, and if you need an orthopedic surgeon he does hip replacements and knee replacements. That's his specialty in ortho.
Mm-hmm.
He is the best of the best.
Oh, well, hopefully I won't be needing any of that anytime soon, but I've had.
Well, hopefully you won't, but if you know someone that does, like, I know so many people who are like on the verge, they really, really need to get that joint replaced and they're just hanging on. The surgery isn't that bad.
Yeah. I
compared to what you get after.
Mm-hmm. Yeah.
So.
I don't want any more surgeries though. I've had enough, so I'm good. I don't want any more.
Me too. I'm good. Really good. If I don't ever have to have surgery again, I will be very, very thankful.
Nope, don't want it. We're good. We are so
good. I don't like the hospital that much. Really, I don't. I can go in, be there as a visitor, but as a patient, I've done my due diligence.
Spend my time, spend my money. I'm good.
Please, I'm good. Yeah, so we have some great physicians. Very proud of that. Very glad personally for that.
Yeah, absolutely. Let's see. So our wards team has come on, and so
good.
We're getting there. I know we.
They're probably trying to grab lunch too.
Yeah, definitely. We've got a few.
I know Dr. Steven.
I was going to say
we have Dr. Stevenson. Sorry.
We keep going. I'm sorry. We have a few folks that are on nights and post call and things like that who just physically can't be here, but we'll get them taken care of when we can.
Sure. We can do one of two things. I can send you this PowerPoint, or they can maybe tune in on Wednesday. Or if you have a small group, say 4 or 5 that can get together at a different time, just like this, like earlier in the morning or later in the evening. If we want to do that, whatever works. If you feel like you've got enough people that have interest and want to do that, I'll be glad to help. Just let me know.
I really appreciate that. I'm also recording this, so we're going to record.
Okay, so then
they can, those folks who can't join in, they can come a little bit later. Hang on one second for me.
Okay.
This is Ashley. Guess they didn't want to talk.
Okay, so if you're recording it, you have to make sure that, I don't look, that I look the very bit. Can you
You look amazing. I promise. You look better than I do.
No, she's recording it? And suddenly I'm like, do I need to go to the bathroom and make sure my hair looks okay?
You look amazing, honey. I promise.
Thank you. Okay. Have you seen these before? They're the coding cards.
I don't know. Perhaps. Kind of hard to see them because I have you way up there at the top.
I know. Right. I didn't expect you to read them, but these are the coding cards that all this information is on.
Okay.
So this is what I'll be using, and I'll just kind of hold them up so they'll know they've probably seen them.
Mhm.
Most likely they have, but these are what I'll bring to you tomorrow morning. There's an inpatient one, and then there's an outpatient office one, just so you know. And I'll give them to you in packets so you'll know the difference.
Okay.
I'm assuming that all of these residents will be in the office and in the hospital at some point.
Of course. Yeah, definitely.
Okay. And all of these residents they've already picked peds as their specialty. So even if they're going into a subspecialty, they're still going to stay with peds. Is that right?
Correct.
Okay. That's always good to know for examples and things like that. I'm doing the OBGYN in the morning. I've never taught those residents before. And the physician that's kind of over it was like, so can you tell us about Medicaid and tell us how to do this and that and the other? And I was like, ooh, that's not in my scope. Sorry. I have no idea. OBGYN to me is very difficult to code. I'll tell you, I'm going to give you the information that I'm getting ready to share with your residents for peds. And beyond that, you need somebody that knows that specifically. I do not.
Yeah. Yeah.
I wish I did, but
I can imagine that would be a little difficult.
it's just different. I mean, like, so Medicaid pays for an OB patient very different from other insurance companies. Well, all the other insurance companies have their way too. I have no idea what that is. I mean, there's just a way to keep up with all that.
Goodness.
But the risk of the patient is so different from the risk of everybody else. So the risk for a peds patient is this really essentially the same as it is for an adult if you have a disease process going on. But how do you assess risk for a pregnant woman?
Right. Yeah. I get it.
So,
I get it.
unless she's considered old, right? I mean, so that ought to be interesting, but it'll be live. So I think that will help me a little bit. I hope.
Hang on. I have one of my residents texting me. Let's see. We're getting closer. You got any questions or anything that I can help you with? You got everything going. Looks, you're going to do great. I know that. So you don't need to worry about it.
Jump in though at the beginning. So like, let me just make sure. If I switch, can you see the side of my slides?
I can see 1, 2, 3, 4, 5.
Okay, so shouldn't I maybe just do a slideshow?
Start from the beginning. Yeah.
Yeah, that's what I need to do. Okay.
Yep, that's perfect.
All right, I'm as ready as I can be. I think I'm good.
Oh, awesome.
Yay.
Dr. Carney is on, so whenever he is ready to get going, he'll chime in and introduce you, and then we'll let you go.
Okay.
Tina, thank you
Thanks
so much for taking the time to do this. I really appreciate it.
You're so welcome. Thank you for getting on early and making sure I was okay to do all this and not going to mess anybody's time up.
We're not worried about that at all. You're going to do great. We really appreciate it. This is important stuff, so thank you.
You're welcome. Let me ask you this real quick. Do I have 45 minutes or an hour?
You have an hour.
Okay. All right. I'm going to try to keep up with the time. Don't have a clock right here. Trying to see, and all my other computer screens are off. So if I'm still talking and it's 5:01, will you chime in and say, hey, you need to wrap it up?
Sure. Well, you have until 1:15, so.
Oh, okay. All right. I should be fine.
Yeah, you'll be good. You'll be good.
Do they have to go to another meeting after this?
Most of them just have to go back to their patient care areas.
Okay. All right. I can't remember. Somebody I'm doing, I have 1 hour exactly, and then they have to move on to something else. And I'm like, that's a lot of pressure to try to make sure that you are exactly on time and that you don't go over.
Yeah, we understand. You know, maybe the PICU might have to, you know, log off pretty quickly, things like that. Those on electives could maybe stick around a little bit longer. So it'll be fine. You have a good solid hour. So
Okay, I shouldn't need more than an hour, especially without being able to show them the card.
yeah.
I should be fine.
Hey everybody, this is Dr. Carney. Thanks everybody for joining us today for our annual compliance training. I really want to thank Tina O'Quinn from Compliance for doing this for us to go over some basics of documentation and coding to give you guys some idea of some of the practice management things that we need to do and be doing when it comes to our documentation and coding. Dr. Stevenson wanted me to remind everybody that you won't be graded on this, so don't worry until you get out into the real world, then you get a grade all the time. But that if you guys have questions after this, that she's happy to answer it. And honestly, the session that we have on Wednesday, along with the internal medicine and family medicine groups, may actually be more helpful because you guys will have walking into it with some more information. And then the other thing that I think will be helpful with this is on September 1st, we're going to be having our outpatient documentation workshop for you guys to walk through some notes in terms of quality aspects of it, things that are good, things that we can improve on with relation to some of the notes that we're doing out in our outpatient clinic. So more to come from that. But I'll go ahead and turn it over to Tina and let her get started with everything. And again, thanks everybody for joining.
Good afternoon, everyone. Can everyone hear me okay? Because I can't see a single face. So I have to assume that you're all there and can hear me and see me okay?
Yep, we can hear and see you.
Okay, good. Again, I can't see anyone except for my face. The internal medicine session that's happening on Wednesday is with Dr. Tracy Voss and myself and Dr. Frank Voss. And it will be very good for you all to have heard this first because we're adding a little bit to that and we'll be talking more in detail about the 2021 changes. I don't know if anybody's heard that there are going to be 2021 changes that will be to your benefit, but we'll talk about those more on Wednesday. So today we're talking about documentation and coding and how important it is to get all that information right. For those of you that don't know me, I am Tina O'Quinn, and I have been historically the coding instructor, or the compliance instructor rather, for the medical group, and have been in charge of teaching residents and new providers that come and join the medical group. And then also I teach a coding class. Since we've merged with Greenville, things have changed and our job titles have changed a little bit. So now I'm considered a senior coding compliance analyst, I think. But we're still trying to make sure that we get all of this information out to all of you guys so that you can have the opportunity to know how to document, and more importantly, how to decide what level of service you should bill based on that documentation and that time that you spent with the patient. So we'll start with just a couple of things. I know I have an hour, but I'm not going to spend a ton of time on things that won't make a ton of difference to you right this minute. So if we're talking about documentation, it is the key to making sure you get paid. But even more importantly, it is also how someone else, another provider, can know what you did to treat the patient. So if you don't do your documentation in a timely fashion, then if you're sending that patient on to another physician to see, then that physician doesn't know what you did and what your impression and plan was for the patient because your documentation hasn't been done. So just be sure that when you are documenting, that you document thoroughly what you did and do it in as a timely manner as possible. You do need to sign and date your note. Even as residents, you need to make sure that you are signing your note and that you're putting the correct attending. If it is your responsibility to say, I'm sending this note to whoever, that is the attending physician that was there for you at the time, and that they're the ones that sign that. If you are working with medical students or and they want to do their own note, that is perfectly fine. But your note as a resident has to be separate from any student note. So you can't use some of their note to make your note better. Just keep that in mind. For your non-Medicare patients, an example of what you might want to say in an office or clinic services: Dr. Hall was present in the clinic and available for consultation. Patient was seen and examined with Dr. Voss. For Medicare patients, the attending must see the patient personally and document their participation and presence there. But as peds go, typically you don't have a lot of Medicare patients. So here's something that's really important. New patients in the office, and I'm assuming that you guys will be seeing patients in the office and in the hospital. So if you're seeing patients in the office, if that patient has been seen within the last 3 years of that specialty, they are no longer a new patient. So you can bill a consult if that's what it is, if that's the service you provided. But new patients are only once every 3 years in the specialty that you are working in. So I can have a new patient in cardiology. I can have a new patient in ophthalmology. I can have a new patient in family medicine. As long as have not been seen in your specialty in the last 3 years, you can bill that. While we're on new patients and office visits, I want to tell you that by and large, consults are going to be there. We are not going to see them getting paid much anymore. So Medicare hasn't paid for consults for the last 8 or 9 years. And now we're seeing several other insurance carriers follow suit with that. And one of the reasons that we're seeing that is because providers nationwide do not understand the definition of a consult. A consult is one provider asking another provider's opinion. Hey, orthosurgeon, looks like Tina broke her arm. Will you check it out and let me know? That's a consult. Rather than, hey, orthosurgeon, Tina broke her arm. There's a bone sticking out of it and she definitely needs surgery. Will you take care of it? That's not a consult. And so what was happening is physicians were billing for consults when they truly weren't consults, and there was just so much money being given back and that sort of thing that they just decided we're not going to pay for consults anymore. Now, Medicaid hasn't followed suit for that and some of the other carriers, but we're seeing more and more start to follow that suit. And for the purposes of what you guys are doing, you don't need to necessarily worry about that. I certainly don't mean for you to start looking at the kind of insurance your patient has, because in the medical group, as long as you stay with us, there is a coding team that will take care of crosswalking your consult to the correct level of service and the correct type of service. I'm telling you this more just so you know that consults are typically not paid, or they're definitely not paid by Medicare, and now they're not being paid by several insurance companies. And that's really all you need to know about that. So evaluation and management services. Some of the things you have to keep in mind when you're thinking about E&M is where's the patient? Where's the place of service? Are you in the office? Are you inpatient or you're outpatient? What type of service are you providing? Critical care, preventive care for age-appropriate physicals or consultations. Third, the patient status. So especially in the office, that's where new patients come and go. New patients are established patients. And then fourth, and the most important part about everything you do is, what is your medical necessity? When the changes come in 2021, medical necessity will drive the level of service that you pick. So it's really, really important that your medical necessity drives what you're doing right now. For evaluation and management services, you need a history, exam, and medical decision-making in order to bill all new patient services, all consults in and out, and all admissions to the hospital, inpatient or observation. So you have a history component of your note. That's the very beginning. This is where it all starts. This is the storytelling part of your note. Okay, so you need a chief complaint. What are you seeing the patient for? History of present illness, review of systems, past family and social history. In the 2021 changes, a lot of that stuff is going to go away, and you'll be able to put in your note what is medically necessary or what you feel is pertinent to what you're treating the patient for, where right now we still have August through December to get through, so we still need to learn what is required for our notes right this minute. So this history component, we start with the chief complaint. What is the patient there for? So even if you're coming into the ED, or you're coming into a room where your patient may be sedated or intubated, you should still be able to get a chief complaint. Someone asked you to see the patient, or the patient got into the hospital for a reason, so hopefully that will be your chief complaint. Why are you seeing them? That can be at the top of your note under the heading of chief complaint, or you can put it in the body of the HPI. Tina is here today for, and list it out. Medicare specifically says you don't have chief complaint, we're not paying you. So just so you know, and that's across the board. Palmetto GBA is our Medicare payer for the state of South Carolina, but if you choose not to stay here, you need to find out who the Medicare payer is for wherever you're going. Lots of times Medicaid follows Medicare. So in this instance, we want to make sure we have a chief complaint. Now, normally I give out cards to you guys, and I did tell Ashley I would bring some by in the morning for you so you could go and pick them up. But on this coding card, if you've ever seen one, let me get a little closer. On the inside, it is the same for the outpatient office card as it is for the inpatient and observation for the hospital card. Up at the top left-hand corner, you have the same history of present illness, just so you know where to look when you get the cards. So for higher levels of service, for your level 4 and 5 new patients, level 4 and 5 consults, for level 2 and 3 admissions, you need 4 elements here. So when your patient comes in with an acute problem, this is pretty easy to get. So let's use the example of right lower quadrant abdominal pain. So we have right lower quadrant abdominal pain, we already have location. So then you're going to ask the patient, well, how does it feel? Is it sting? Does it burn? Is it stabbing? Is it constant? Is it throbbing? So quality is pretty easy to get. On a scale from 1 to 10, how severe is your pain? How long has this been going on for duration? Timing, what time of the day? Or does the right lower quadrant pain come before you eat, after you eat, at night, in the morning, whatever? Context is, what else is going on? So I was climbing the stairs, or something like that, that gives us a little bit more information about how that pain is happening. Modifying factors, are you taking any medicine for it? And does it help? So yeah, I'm taking a leave, it's not helping. I've been taking it for 10 days, hadn't helped at all. So then you may ask, why do you keep taking it? And then associated signs and symptoms. So I have right lower quadrant abdominal pain. Your questions might be, have you had any nausea, diarrhea, constipation, vomiting, fever, chills, things like that, as you are just trying to figure out the story that you're telling for the patient. Why are we here, and what information do I need to help me get to what is wrong with the patient? So we have that history of present illness. And then one of the things that's going away, and I'm very glad that this is going away, in that you will not be required to do 10 review of systems. So right now we're still talking to the patient. We haven't touched them yet, and we have to review what else might be wrong with your patient besides the right lower quadrant pain or whatever's going on. So an example might be, have you experienced blurred vision, tremors, muscle ache, swelling, headache? So it's not a list of diagnoses or disease issues. This is what else is going on with it, with this pain that you're having. Is there anything else I need to know? So non-contributory, unremarkable, and negative as far as review systems go are not accepted by insurance companies. So You can put negative except for HPI, but if you do that, make sure that those HPI elements that we just talked about, that location, quality, severity, all of that is set aside. You can't get that information again for your review of systems. So if you're going to put it in your HPI, you need to make sure that you have a separate line for those, so we can differentiate from your HPI elements and then your review of systems. It is okay in the state of South Carolina for Palmetto GBA. They do say you can list your pertinent positives and or your pertinent negatives, and then put all other systems negative, and you get credit for 10. I highly recommend you do that. Only list the things that are important to you as far as treating your patient today for that problem. And then all those systems negative gets you credit for 10, and you don't have to spend a lot of time clicking on different check boxes to make sure 10 are met for that requirement. So there's 14 here. Right now you're required 10, or again, all other systems negative after your pertinent positives and or your pertinent negatives. So what does that look like? Well, it can look just like this. Patient complains of joint pain, tenderness, headache, muscle aches after walking, no fever, chills, nausea, vomiting, diarrhea, all those systems negative, and you get credit for 10. And after the review of systems, then typically we have a past medical history. Again, you don't have to put this under a heading unless that's what you choose to do. You can just put this all in the HPI, past medical history of whatever that may be. Immunizations and vaccinations are perfectly fine for children who really don't have a past medical history. So immunizations, allergies. So if you're going to say patient has allergies, then what's the reaction to the allergy? Or your dietary status, especially for children who have specific things that they are unable to eat. Family history. So a lot of times the family history is the one that is missed because it is felt to be unnecessary for certain types of patients, like trauma patients. So it's really very hard for our trauma surgeons to get a family history when the patient has a broken femur or has something that is emergent that needs to go to the OR and that sort of thing, or critical care. But the family history for peds a lot of times is very important because this may be something that has been passed down from the parents or the grandparents, or something that a brother or sister may be experiencing as well. So the family history, again, you can't put non-contributory or denies or unremarkable, but you can say the health status or cause of death or parents or siblings or children, or there is no family history for whatever it is that you're seeing the patient for. So no gastrointestinal family history of anything, no Crohn's colitis or that sort of thing for your patient that has right lower quadrant abdominal pain. And then the last history is the social history. And of course the social history, everyone has one. So lives at home with whoever they live with. They go to school, they have brothers, sisters, whatever the level of education. If there are drugs and alcohol or tobacco as a part of this social history, of course, you'd want to know that. Social history is pretty easy. Just make sure that you put something in all three of these histories. So you have a chief complaint. You have 4 elements of the HPI. You have 10 review of systems or your pertinent positives and or negatives with all other systems negative, and then something in the past family and social history. All right, all of those things can be templated, whether you're going to stay here or if you're leaving or what have you. If you stay here, you're definitely going to be working with Epic, hopefully in February. We will have this templated out for you so that you don't miss these things. You'll be able to template it in a fashion that makes sense to you. So your template may not look like everyone else's, but there's no reason to miss this stuff because you can put it in a template so you don't forget. There is one good thing about the history portion of your note. If for some reason you are unable to obtain this entire history, so let's say the patient was in a lot of pain and the parents don't speak very good English and you were unable to obtain the histories, or maybe you couldn't get all the review systems, you can say, The remainder of this, the rest of this history portion is unable to be obtained due to what? Is there a language barrier? Is the patient just unable to speak because they're in a lot of pain or because they're intubated or whatever? For the history section in the office and in the hospital, you are able to say that. So just keep that in mind. If you can't get all your questions answered, as long as you put in there that you are unable to obtain it and why, you get credit for it. It's the only place in your note that you're able to say, I couldn't get it and still get credit for it. Remember that non-contributory and unremarkable do not count in any part of your history, so leave those terms out of your documentation. The next thing we want to talk about quickly is the exam. And for the exam, we have two different types of exams. Most of you are going to use the 1995 exam. Love how these are named. So we have a 1995 exam and a 1997 exam, and boy, they really thought about those titles, didn't they? So for 1995, primary care physicians and the AMA basically decided that a comprehensive exam would be 8 organ systems. And again, when you look at your cards that I'm going to give you, on the inside of the card, there are 2 different types of exams. So one of them is all the organ systems and a couple of body areas. And so we're going to go over that for a minute, listed inside the card. And then, so in 1995, all the physicians decided that an 8 organ system exam would give everyone a comprehensive exam, and that would be fabulous, right? Except, how do you think the ophthalmologist felt about that? So, Tina, I want you to jump up on the table. We're going to listen to heart and lungs, pressure on your belly, check your range of motion. We'll get to your eyes in a minute. So an ophthalmologist is never going to need to do an 8 organ system exam, but does that mean that they never get to build the higher levels of service, that there's never any risk or history that's needed to treat that patient? So that really wasn't fair, and the specialist just went nuts over it. So it wasn't just ophthalmology, it was neurology, it was a lot of peds, where the orthopedic surgeons who truly do not need an 8 organ system exam, but that doesn't mean that their visit isn't comprehensive, right? So it took them 2 years to get around the table again, and this time it was a specialist, and they decided that everyone in every specialty would be able to have their own exam. And they did, they do. So now you can decide, do you want to do an 8 organ system exam? And lots of you will want to do that. And then for the specialist, you have your own exam. So for urology, for cardiology, for neurology and neurosurgery, for everything that you guys have in peds, you can decide, do you want to do an 8 organ system exam, or do you want to do the exam that is specific for your specialty? So I know you can't see the card at all, but when you get it, I'd like for you to be able to kind of take a look at it and see what it looks like. Here is how it's broken down for the 1995, which is on your left, and specialty exam, which is on your left, on your right, excuse me, to get to a comprehensive exam. But when you look at the card inside, and I know you can't see that, we have a general multi-system exam, and it lists organ systems and it lists body area. So I want to talk about that really quickly when you get your card. So the constitutional, this is the information that you get usually from someone else. So a nurse or an MA in the office may be getting this information for you for the constitutional, the height, weight, blood pressure, systolic, diastolic, pulse, maybe temperature. If we get height and weight, then Cerner will give you BMI, and sometimes that's very important. But all that information, whether obtained in the office or in the hospital, is gotten in the note from someone else, and you are able to use it as one of your exam components, as long as you make sure you review it. So it might be very important to look at it to see that your patient's blood pressure has either spiked upward or downward, or maybe that there's a weight gain or loss that's been significant since the last time you saw the patient, and that sort of thing. So be sure you're looking at that information. The eyes are separate from the ears, nose, throat, and mouth. Okay, so you want to put eyes separate, or if you're going to put them together in one string, and I do see often HEENT. So we have head, eyes, ears, nose, and throat. You can do that. But remember, the head is not an organ. So if you're counting organ systems, the head is not an organ and it doesn't count. However, if you are one of those physicians that likes to put head, normal cephalic, comma, eyes, pupils, normal and reactive to light, comma, normal oral mucosa, then you do get 2 organ systems still, because you've got eyes and you've got mouth, and those are the 2 things that you need for those 2 organ systems. The head doesn't count against you, it just doesn't count toward one of your organ systems. Okay. The next thing is the neck. The neck is not an organ either. It's a body area. So it depends on what you're looking for in the neck. If you're looking for JVD, that's cardiovascular. If you're feeling lymph nodes, that's under lymphatic. Okay, so if you want to put neck in your organ system exam template, you won't get credit for that either. Now, I'm not saying that you can't put neck in your template. You can, but you're not going to get credit for head or neck in your 8 organ system count. All right, the next thing is respiratory, and the headings are very important to us. Palmetto GBA specifically says if you use headings, then you need to put the right header for the organ system, not the body area, unless you're doing body areas. You can't mix them, so you can't have some organ systems and some body areas, so you need to do one or the other. We teach organ systems here, and the reason we teach organ systems is because body areas gives you very limited information, and you have to examine both the right and left arm and right and left leg, and sometimes that just doesn't seem very medically necessary. So that's why we teach organ systems. And we wanted to put some elements of the body areas in here should you choose to go that way. But I promise you it'll be a lot harder to get that information than it will if you template your 8 organ system exam. So respiratory, the organ system, cardiovascular, the organ system. So we're not just talking about heart and lungs here, we're talking about the whole organ system. So my cardiologist, and I dearly love my cardiologist, they like to say extremities, no edema. That is cardiovascular. They don't get credit for that if they put it in their note separate. We don't count it against them again, but we certainly would like them to put it in the cardiovascular area since that's the organ system that's being examined. Then we have gastrointestinal, not abdomen, because gastrointestinal is an organ system. The abdomen is a body area. Genitourinary, that is one of the elements of the exam that you can choose to put into your template or completely leave it out. Depending on what subspecialty you're going to under PEDS, you may or may not need to build that into your template. Lymphatic is next, then musculoskeletal. And the last 3 on the card are skin, neurologic, and psychiatric. I see many, many, many notes that have the neurologic and psychiatric up right under the constitutional information where they say general, patient is in no apparent distress and alert and orient times 3. Please put your information in those headings so you get credit for them. If you put them in your general header, you do not get extra credit for it. It gets swept up into that constitutional organ system, and you're leaving 2 organ systems on the table, which, by the way, if you have 6 organ systems instead of 8, your level 5 consult or new patient just went to a level 3. So when we talk about E&M services, and I know I'm talking fast and there's a lot of information I'm trying to give to you all at once, one of the things that you need to understand is this is how you get paid. And we want to make sure if you're doing the work, you get paid for the work you're doing. So that's one of the reasons we do this. Of course, good documentation is good for you and all the people that are working with that patient so that they know what you're doing and you know what they're doing. But as far as this exam goes, you want to make sure you get credit for things you're doing. So when you're looking to see if your patient is in distress or if they are alert and orient time 0 to 4, that you're documenting that in a place that you get credit for it so that you can bill those higher levels of service when they are medically necessary. All right, so you see here on the screen, exam of 8 systems will give you a comprehensive exam. It can look just like this. You can label it out in a line or you can put it just like this. Either way is fine. 8 organ systems. You can template these so that you don't have to put those in every single time. You just have to put the information in where they belong. So let's look at this real quick. So you have 8 organ systems. That's comprehensive. You're good. If you have a comprehensive history that we just talked about, and now you have an 8 organ system exam, you're good to go. Now you're set for a level 4 or 5 new patient or consult. But if you did it like this under the 1997 guidelines that have bullets, so when you see the card again, you'll see these little black dots that are lined up after the organ systems. If you choose to use the 1997 guidelines, then you need 18 bullets, and it says it at the very bottom of the card. It's very tiny right down here at the very bottom. It tells you you need, for a comprehensive exam, you need 2 elements and at least 9 areas or 18 bullets. So you can do 8 organ systems, or if you take that exact exam, you only have 11 bullets, and that's going to give you a level 1 admission versus a level 3 admission if you've done the 8 organ systems. Now, for all of you that are going to a very specific specialty, we do have specialty exams for you. And if you'll let me know if you would like to see your subspecialty or specialty exam under PEDS for the 1997 guidelines, I will be more than happy to send that to you electronically, or I could bring it by and give it to Ashley, either way. So hopefully, I can't see any of you at all. Does anybody have any questions up to this point? Okay, I assume no. If there is a part, let me go back to this. If there is a part of the exam that you are unable to obtain for whatever reason, maybe the child is not allowing you to do the examination. If you are unable to do part of the exam, you cannot count it. You can't say, well, it was deferred because. So for the exam, you only get credit for what you can do. So an example would be in our neurology office. The neurologist decided that they wanted to use the 1997 specialty exam, and the reason they did that is because it is very specific to cranial nerves. But a couple of their physicians were leaving out one of the bullets, which was memory. So they had to put that back in. And the other one was gait and station. And so under gait and station, they said deferred because the patient couldn't walk. Okay, well, if you say deferred, that means you're not getting credit for that. So they were doing, they have a 23 bulleted exam that is specific to neurology that they have to complete, and they weren't getting that bullet, which again was taking their level 3 admission to a level 1 admission, or their level 5 consult to a level 3 consult for one thing. And they were saying, well, it's deferred, the patient can't walk. So the better choice was for them to say under gait and station, patient unable to ambulate is sitting or lying in bed. There's your station, sitting or lying in bed. Patient's unable to ambulate. So that one little bullet can be checked off as we did that part of the exam. Deferred means you didn't do it. Doesn't matter why. So that's how we got them back to getting credit for their 23 bulleted exam so that they could build those higher levels of service. All right. Medical decision making. It is on the back of the card that you'll get. It's the same on both cards. Again, there's an inpatient admission and inpatient consult card, and then there's, or inpatient admissions, inpatient or observation, and then there's the card that has the new patients and consults on the other card with established patients in the office. Either card's going to be the same on the inside and on the back of it. And the back of it is just medical decision making. And this truly is the most important part of what you guys, sorry, trying to keep track of my time. This is really the most important part of your note, because in 2021, you're going to either be able to bill on time, which will be very good, or you will be able to bill on medical decision making. So where's your medical necessity? Where's the risk for your patient? How are you going to treat them going forward? And that sort of thing is what is going to drive the level of your note and the level of service. So medical decision making is the nature of presenting problems, the data used to assess the diagnosis, and then the complexity of the patient's condition. Where's the risk? So when we look at the card, this is a lot easier seeing there. At the top of the card on the back is where you get this information right here. So there are three components of the medical decision making. It is diagnosis points, data points, and where you land on the table of risk. We will pick the 2 out of the 3 elements that are the same or higher so that we get you to the highest level of service where it comes to medical decision making. So under the diagnosis area, you have diagnosis on one side of the card and data on the other. You cannot combine these. You do have to get points here. So you get 1 point and a max of 2 for self-limited or minor problems, 1 point for every established problem that's stable, 2 points for every established problem that's worsening, a new problem with no additional workup, and a new problem with additional workup. So let's think about this. So you have a patient that's coming in today for right lower quadrant abdominal pain. You've gotten a comprehensive history, you've gotten a comprehensive exam, and now you're here with this new problem of right lower quadrant abdominal pain. Well, most likely, you're not going to be able to assess what's causing that pain without some sort of test, right? So the test may be an ultrasound. It may be an x-ray, it may be a CT, it may be an MRI, could be blood work. Anything that is going to help you diagnose what's causing that right lower quadrant pain can be additional workup. It can be as simple as I go to the physician and I see, or I tell a physician I am having painful urination. They're most likely going to give me a cup. And when I bring that cup back with my urine in it, they will stick a dipstick in it to see if there's bacteria. And if there is, they'll give me a prescription, right? That cup is additional workup. It changes my symptom to a treatable diagnosis. So anything that you do that takes that symptom or helps you identify what's wrong with your patient is considered additional workup. So you can have as many of those as you want, but the maximum points that you need here is 4. So if you have a new problem with additional workup, you've maxed out how many points you need to get and you can move on. Or you can get your points over here in the data area. Here's the thing though, you only get 1 point for reviewing and ordering as many labs as you need. You don't get a point for every lab, it's all labs. Same with radiology. If you did order the CT and the ultrasound and the MRI, you would still just get 1 point. Even if you ordered and reviewed it, you still just get 1 point. Review or order medical tests, that would be something like an EKG, EEG, echo, stress test, those sorts of things. Again, 1 point. So for the cardiologist, if they order an echocardiogram and a stress test and some blood work, they get 1 test for the 1 point for the blood work and 1 for the echo and the stress test. So they get 2 points here. If you'll look at the very end of the list here, review and summarization of old records. So if you do summarize old records, and that could possibly be, especially in PEDS, you may have a child that's moving from one place to another and they bring you all the records from another place. You have to make sure that you summarize those old records in the note for the day that you're seeing and billing for that patient. Okay, if you don't do a summarization of them, then you don't get those 2 points. It's a little harder to get the points over here in the data area, but you can. And we will take whichever area you get the most points in. So if you have 2 points in the diagnosis area, but you have 3 points in the data, we're taking the 3 points. But just take a look at this. Most of your patients, your new patients, you should have either a new problem with no additional workup. So I have a cold and sinusitis. So there might not be any additional workup. You may just say, let's try some over-the-counter medicine first and see if that works. So there's no additional workup there. So that could happen definitely to you, or the additional workup. So for your new patients, this isn't such a problem. And then just remember, when you're seeing me and follow up, either I'm stable Or, and I'll take this worsening a little further, it's not just worsening, it's failing to change. So if I have hypertension and you put me on 2 medicines and I come back and my blood pressure is not worse, but it's not better, and that means you have to think about, do we need a third medicine, or what do we need to do about this? That failing to change makes you have to make some more decisions, then that's 2 points. So for lots and lots of follow-up patients, you'll see that you have at least one established problem worsening, or if you have 2 or 3 or 4 established problems stable, you can add all those up. So either way it goes, it typically is easier to get your points here, but again, it doesn't mean you have to. We'll take either one. And then the table of risk, and this is really easier to be seen on this card here because it has the whole table of risk here. So we have minimal, low, moderate, and high. I don't think. Okay, so here, medical decision making, right hand joint pain. We will schedule her today for an x-ray and CBC. Depending on the x-ray results, we may proceed with joint injections. I will also let the patient know of the CBC results. Patient was informed to go directly to the emergency room if the pain worsens. So we have diagnosis points 4, new problem with additional workup. All right, because we're going to send the patient for x-ray and blood work. And then you have data points where you reviewed and ordered labs and a radiology test. Well, we're going to drop the data points because we've got 4 points in the diagnosis area. And then under risk, if you're looking at the card specifically or the table of risk, you'll see under the moderate category, an acute illness with uncertain prognosis puts you in the moderate field. So if you have a comprehensive history and a comprehensive exam and you land here in your medical decision making with 4 points and in the moderate area, you have a level 4 new patient or consult, either one. The criteria is the same. The difference between a new patient and a consult is, are you taking over the patient, or did someone ask you for your opinion? If they didn't ask for your opinion, then you don't need to be billed a consult. But this is a level 4, okay? So your medical decision making falls under the moderate area on the table of risk. Let's see if I can get... Sorry, I'm looking to see if I can find the table of risk on here, but we usually have the card, so we don't have this problem. But on your table of risk, there are lots of little dots here and boxes. So you have boxes for the presenting problem, the diagnostic procedure, and the management option. So there's 3 boxes, and there's bulleted items in every single box here. You only need to hit 1 bullet in one of those boxes. So if you hit a bullet in the low category on the table of risk and you hit a bullet in the moderate category and you hit a bullet in one of the high boxes, we're going to give you the high risk. That means you have to have 4 points in the data or the diagnosis area. You need a comprehensive history and a comprehensive exam. That's how you get to those level 5s. Or here for your admissions, if you look here, so for your admissions, the same sort of thing. 4 points in the diagnosis area, 2 points in the data, so we drop that. Moderate risk on your table of risk, and you have a level 2 admission. Just so you know, the level 2 admission and level 4 consult need to meet the same criteria. The level 3 admission and the level 5 consult are the same. Again, are you taking care of the patient, or did someone ask you to see the patient? So hopefully that's sort of making sense to you. So we have history exam, medical decision making. How do I put all this together? Again, here you have an admission example. So your history, you have a chief complaint, you have 4 elements of the HPI, you have 10 review systems, and you have 1 element in all 3 histories. That gives you a comprehensive history. For your exam, you have 8 organ systems or all bullets. So you're good with a comprehensive exam. So it comes down to, is this a level 2 or level 3 admission? Well, when you turn your card over on the back, you have 3 points in your diagnosis. Maybe you have 3 points in your data as well, but even if you didn't, if you fall in the moderate risk, that's your level 2 admission. Your level 3 admission is if you had 4 points, that's the most you need in either place, and you fall in the high risk. So let me tell you another example for the difference between the moderate and the high on the table of risk. So the moderate, the first box says 1 or more chronic illnesses with a mild exacerbation. So that's someone whose blood pressure maybe needs to be tweaked. Maybe it's 150 over 110 or 100 even, and they're on 2 medicines and you may need to tweak that. You're not terribly concerned. You're thinking, well, maybe some hydrochlorothiazide or something like that would help that hypertension. And so you throw in another medicine to see if that helps. That would fall in the moderate box. The high says 1 or more chronic illnesses with a severe exacerbation. So that's someone who you're thinking, if we don't treat them now, something really bad's going to happen. Or we're on the cusp of admitting if you're in the office, or maybe that is why you're admitting at the highest level, because you do have a severe exacerbation of something. So do you have a mild exacerbation, or do you have a moderate exacerbation, or severe rather? Acute or chronic illness that poses a threat to life, that's going to be high risk, versus prescription drug management, which would be moderate risk. So when you see the card, this will hopefully all kind of come together and make a little bit more sense and help you be able to know what level of service you need to go with. So what about established patients or even hospital rounds? So subsequent hospital care codes only require 2 of the 3 components, and the components are the history exam and decision making. So if we look at that, here's your hospital rounds, and you can see the different requirements for the 3 different levels. So if you have a chief complaint that doesn't get to that level 2, but your exam and your decision making land you in that level 2 visit, then it doesn't matter that the history didn't meet the criteria, because you only need 2 of the 3 components. Where for new patients, new consults, and admissions, you need the history exam and decision making. For hospital rounds and established patients in the office, you only need 2 of the 3. So if you've got a brief exam of 2 to 7 organ systems and 3 points either on the diagnosis or data and the moderate risk, you have a level 2. The level 3s are usually for your patients who are very sick and are not responding to medicine, or they're still intubated, or they're still in a high risk category for whatever reason, and they still need a lot of attention given to them. So this is a lot of times used like right after the admission, maybe. You need to follow here, or sometimes your patients go straight to a 2 because they're easily treated. So that's the difference there. Again, consultations are one provider asking another provider for their opinion. If that opinion is given within the medical group, then or in an inpatient setting, you don't have to send a letter to anyone explaining what happened, because it's a shared record, so we don't need to do that. But if someone comes to you outside of the Prisma network, so in the Prisma network I include Greenville. If they come to you outside the Prisma network, then, and it is truly a consultation, someone's asking your opinion, then you do either need to send the note back to that requesting physician, and or a letter explaining, well, this is what's wrong and this is what we're going to do to treat it, so that that referring physician knows exactly what you're doing to treat their patient. More things to remember. So your signature validates the documentation. Amendments and late entries dated actual date of the entry date. All inpatient entries must have a complete date, time, and signature, and the supervising attending must co-sign everything. Billing is based on the physician who is physically present. So again, that's very important. Abbreviations, if someone else doesn't know what that abbreviation is, then you probably don't need to use it. So we basically say, if you're going to use abbreviations a lot, use the Stedman's PH standard. And then things to remember: residents must write their own notes. You can't copy the students, and you can't say agree, seen and agree with above, and your attendings should not do that as well. Your attendings attestations need to say seen and examined. So that's something to keep in mind. Also, there are ways for us to bill on time, and I will go over that with you probably when we teach the 2021 rules. We will talk about how time is going to change so that you can bill on time. But just so you know, that every single E&M code has a time listed right under them. Again, on the card, you'll be able to see that a new patient level 5 is 60 minutes. So if you can do your new patient assessment in 30 minutes and you meet the requirements for the history exam and decision making, then we don't care how much time it took you, and you don't need to put time in your note. For right now though, if you find that you spent greater than 50% of that 60-minute visit in counseling and in coordination of care, and you might do that for someone who's getting a diagnosis that's hard to understand or hard to treat, or that has lots of options, you might find that you're spending the bulk of your time, greater than 50% of the whole visit, in counseling and coordination of care. Not while you're a resident, but when you get out to be your own physician working in your own practice, you'll be able to bill on time. I don't want to spend a ton of time on it since you guys can't bill, so the attending can't use your time, and time is getting ready to change. So just know that there is a way to bill on time, and then when 2021 comes, it's not going to be based on greater than 50% of the total time spent in counseling and coordination of care. It's going to be the total time spent, and you'll get to bill for the time that it took you to review the note or the patient's history before they come in, and you'll also get to bill for the time that you spend with the patient and in coordination of care. And we'll talk about that a little bit on Wednesday. And then of course, if you have more questions after that, we will be teaching these new 2021 guidelines all the way up to January 1. So you'll hear a lot of information, and it's going to make your lives a lot easier. So that 10-point review of systems and 8-organ system exam will not be what drives your level of service. Medical necessity will drive your level of service. Either the time it takes to see you and form a plan that you understand, or just the risk of what is wrong with you or your patients, and the medical necessity risk for being treated with this versus that, and that sort of thing will drive the level of service. So it's going to get a little easier, and we don't have long to go, but for right now, what we just went over is what you need to follow. I feel like you guys probably didn't maybe get all of this as easy as you would if you'd had the cards in front of you and that sort of thing. So Ashley knows how to get in touch with me. Dr. Stephen knows how to get in touch with me. If you guys want to reach out to me and have me come and do a smaller session or answer questions, I am more than happy to do that if you'll just let me know. And if you have questions after Wednesday, after we talk about some of the same stuff and then more to do with the changes, if you find that you're scratching your head going, I'm not really sure what we're supposed to be doing now, please don't hesitate to reach out to me so I can maybe see if I can answer those questions for you now. Again, I can't see any of you, so I don't know if you have questions. Anybody? That's all I have for you today. I think Ashley is recording this for the people that can't be here. Dr. Carney, do you have any questions or anything to say along with this? Okay, well, I'm assuming that since I can't see any of you and I can't hear anything, that you guys are good. Here's my phone number. Here's my boss's phone number. So either one of us will be more than happy to answer any questions you may have. I will bring the cards by tomorrow morning for Ashley to have in the office if you would like to come by and get some. And again, she'll have my phone number and email address if you have any other questions. Thanks so much. I hope this was beneficial to you to some degree, and look forward to working with you in the future. Thanks. Bye-bye.